Some B12 deficient patients see nerve improvement in as little as 14 days, but only if they catch it before the window closes. Up to 40% of adults over 60 are quietly running low on this single vitamin, and for some of them, it is silently destroying their nerves right now. That vitamin is B12, and what makes this story so urgent is that when caught early enough, the nerve damage it causes can actually be reversed, in some documented cases, within as little as 14 days. Over the next 20 minutes, we are going to walk through the science of how that happens. We will cover what B12 does inside your nerves, why your body stops absorbing it as you age, and exactly what the clinical research shows about how quickly nerve repair can begin once you correct the deficiency. We will also cover the common medications that drain B12 without your doctor necessarily warning you, the blood test numbers that actually matter, and the narrow window of time you have before nerve damage locks in permanently. Everything you hear today comes directly from peer-reviewed medical research, and we are going step by step. Section 1. Why your body stops absorbing B12 after 60. To understand why B12 deficiency hits seniors so hard, you need to understand what changes inside your stomach with age. A condition called atrophic gastritis gradually thins the stomach lining and reduces stomach acid production. Framingham's study data showed it affects 24% of people in their 60s, and that number climbs to 37% after 80. A 2025 autopsy study published in Age and Aging found atrophic gastritis in nearly 48% of people over 70, which means close to half. Stomach acid is what separates B12 from the proteins in food. Without enough of it, the B12 in your steak, your eggs, your fish passes right through you, because your stomach cannot unlock it. But here is the distinction that matters. Crystalline B12, the kind found in supplements, does not need stomach acid to absorb, which is why supplementation works even when food absorption fails. H. pylori infection compounds the problem. A review published in the Hong Kong Medical Journal found it in 56% of B12 deficient individuals, and it speeds up gastric atrophy. And then there are the medications, which is where this gets personal for a lot of people. Metformin, the most widely prescribed diabetes drug in the world, carries a dose-dependent B12 risk. A meta-analysis of 31 studies and more than 8,000 patients found metformin users face a twofold higher risk of deficiency. People taking 1,500 to 2,000 milligrams daily had an adjusted odds ratio of 3.34 compared with those on lower doses. And in 2022, the United Kingdom's MHRA reclassified B12 deficiency as a common side effect of metformin. Not rare, common. Proton pump inhibitors, medications like omeprazole, lansoprazole, and pantoprazole that millions of Americans take for acid reflux are another drain. Kaiser Permanente ran the largest study on this, and 2 or more years of PPI use raised B12 deficiency risk by 65%. Higher doses nearly doubled it. Combine metformin with a PPI, and deficiency rates jumped to 34%. Pernicious anemia, an autoimmune condition, affects about 1.9% of adults over 60. Dietary restriction adds another layer of risk. Gastric bypass surgery produces deficiency in 20 to 62% of patients. Even nitrous oxide exposure can directly inactivate B12. Section 2. How B12 deficiency destroys your myelin sheath. Understanding how B12 protects your nerves is the key to understanding why replacing it can undo the damage. Your nerves are wrapped in a protective coating called the myelin sheath. Think of it like the insulation around an electrical wire. Without that insulation, nerve signals misfire, slow down, or stop entirely, and B12 is what your body needs to build and maintain that coating. The first pathway runs through methylcobalamin. It serves as a coenzyme for methionine synthase, an enzyme that converts homocysteine to methionine. Methionine then becomes S-adenosylmethionine, known as SAM, your body's principal methyl donor and the molecule responsible for synthesizing myelin basic protein. When B12 drops, SAM drops with it, myelin production stalls, and homocysteine accumulates to levels that are directly toxic to nerve tissue. The second pathway runs through adenosylcobalamin, B12's other active form, which acts as a cofactor for a mitochondrial enzyme. When B12 is low, a substance called methylmalonic acid, or MMA, builds up. Your nerves essentially get rewrapped in faulty insulation. More recent research uncovered a third pathway. B12 deficiency shifts the balance of inflammatory cytokines in your body. All of this leads to a condition called subacute combined degeneration, demyelination of the spinal cord, that appears on MRI as a pattern doctors call the inverted V sign. But long before it reaches the spinal cord, the damage typically starts in the longest nerves, the ones running down to your feet. So can you actually reverse nerve damage with B12, and how quickly does it happen? The answer, based on multiple lines of evidence, is yes, but with caveats that matter. The strongest evidence comes from randomized controlled trials. The best single trial, published in the journal Nutrients in 2021 by DeDangelos and colleagues, took 90 type 2 diabetics on metformin and randomized them to either 1,000 micrograms of methylcobalamin per day or a placebo for 12 months. What happened was clear. The treatment group showed measurable improvement in nerve conduction velocity, vibration perception, pseudomotor function, pain scores, and quality of life. The placebo group deteriorated over the same period, which means not treating made things actively worse. A 2022 meta-analysis of 6 randomized controlled trials published in Curious confirmed B12 supplementation reduced neuropathic symptoms and pain scores compared to controls. Now, about the 14-day time frame, this is where precision matters. Case reports in the medical literature do document rapid improvement. One report in the journal Revue Neurologique described a 56-year-old patient whose neuropathy improved within days of starting intramuscular hydroxycobalamin injections, with complete resolution at 3 months. A physician published an autobiographical case report in a peer-reviewed journal describing how his own hand and wrist pain from B12 deficiency completely disappeared 2 weeks after starting injections. Another report in Nature's Spinal Cord Series and Cases tracked patients with acute B12 deficiency spinal cord syndromes who showed improvement at 2 weeks to 1 month. A systematic review found methylcobalamin produced significant symptom reductions within 4 weeks, with up to a 96% reduction in tingling and a 99.2% reduction in burning sensations by 12 weeks. Animal studies demonstrated visible myelin protection at the 14-day mark with B12 treatment after nerve injury. What does the real-world recovery timeline look like? Blood. B12 levels typically normalize within 1 to 2 weeks. Energy picks up within days. Early neuropathy improvement, meaning less pain and tingling and burning, often surfaces within 2 to 6 weeks. Measurable changes in nerve conduction take 3 to 6 months, and the full extent of recoverable function usually becomes clear between 6 and 12 months. 14 days represents the fast end of the spectrum, initial symptomatic relief. That is real and documented, but it is not the whole picture. Full recovery takes months, and the earlier you begin, the better the outcome. And that brings us to the most urgent part of this entire conversation, because the window for reversal does close. Residual disability persists in approximately 6% of neurological patients and tends to become permanent when it lingers past 6 to 12 months of treatment. Delays of more than 6 months between symptom onset and diagnosis are strongly linked to irreversibility. A review of 57 patients found that B12 therapy improves deficits in most people but achieves complete resolution in only a few. Shorter symptom duration and less severe disease at diagnosis were the 2 factors most associated with full recovery. The distinction that drives this is between demyelination, which is damage to the myelin sheath that can potentially be repaired, and axonal degeneration, which is damage to the nerve fiber itself and is often permanent. Warning signs that damage may have crossed the line into irreversibility include a positive Romberg sign, a positive Babinski sign, and MRI scans showing involvement of 7 or more spinal segments. Every month of waiting is a month the damage inches from reversible toward permanent. Early detection is everything. B12 deficiency is not the only thing that damages nerves in seniors, and getting the full picture matters. A large French study at Pitié-Salpêtrière Hospital examined 785 elderly neuropathy patients and found that the most common diagnosis was actually idiopathic neuropathy, meaning no identifiable cause, at 35.4%. Diabetes ranked second at 18.8%. About 50% of all adults with diabetes develop peripheral neuropathy during their lifetime, and 35% already have it at the time of their diagnosis. Idiopathic neuropathy, the unknown cause category, accounts for 25 to 46% of all cases depending on the study, which means millions of Americans have nerve damage with no explanation. Some of those patients may carry undiagnosed B12 deficiency, prediabetes, or other conditions that standard workups missed. Alcohol-related neuropathy shows up in over 46% of chronic alcohol abusers based on nerve conduction testing. Chemotherapy-induced neuropathy hits 56 to 68% of patients receiving neurotoxic drugs. Chronic kidney disease causes neuropathy in 50 to 80% of dialysis patients, and postherpetic neuralgia, nerve pain after shingles, affects 10 to 18% of people who develop shingles. The point here is straightforward. B12 supplementation is absolutely worth investigating if you have neuropathy, but a thorough evaluation by your doctor is what identifies the actual cause. Let us talk about what to actually do about B12. The official recommended dietary allowance for all adults, including seniors, sits at 2.4 micrograms per day. But the NIH adds a specific recommendation. Adults over 50 should get their B12 through supplements or fortified foods rather than just regular food, because food-bound B12 absorption declines with age. Therapeutic doses for correcting a deficiency run dramatically higher than the RDA, typically 1,000 to 2,000 micrograms daily. That works because even without proper stomach absorption, about 1 to 2% of oral B12 enters the body through passive diffusion, which means 1,000 micrograms by mouth delivers roughly 10 to 20 micrograms absorbed, well above the daily requirement. When it comes to forms, 2 of the 4 types of B12 matter most. Cyanocobalamin is synthetic, the cheapest, the most stable, and the form used in most clinical trials. Your body converts it to the active forms. Methylcobalamin is one of 2 biologically active forms, and nerve tissue takes it up preferentially. Preclinical evidence for nerve repair, including promotion of Schwann cell differentiation and myelin protein expression, is strongest for methylcobalamin. It costs more and breaks down faster in light. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. No head-to-head clinical trial has definitively proven methylcobalamin outperforms cyanocobalamin for neuropathy outcomes, but the preclinical weight tilts toward methylcobalamin for nerve-specific applications. On the question of injections versus pills, a 2025 meta-analysis in Frontiers in Pharmacology found no statistically significant differences between oral, sublingual, and intramuscular routes for raising serum B12 levels. The Cochrane review reached the same conclusion, that oral B12 at 1,000 to 2,000 micrograms per day performed as well as intramuscular injection, and one study actually found oral 2,000 micrograms outperformed injections by a mean difference of 680 picograms per milliliter. Sublingual B12, the kind you dissolve under your tongue, does not appear to outperform regular oral tablets based on the available research. Most guidelines still recommend starting with intramuscular injections when neurological involvement is severe, then transitioning to high-dose oral for maintenance. On safety, no established upper intake level exists for B12, and it is generally considered very safe. The only notable signal came from one cohort study linking high-dose B12 supplementation over roughly 10 years to increase lung cancer risk in male current smokers. But that finding was specific to male smokers and remains unconfirmed in randomized controlled trials. Section 7. The blood test numbers that actually matter. If you take one thing from this video, let it be this. A standard serum B12 test may not be enough. 200 picograms per milliliter is the standard deficiency cutoff. But between 200 and 300 lies a gray zone where up to 40% of people carry functional deficiency, meaning their cells are starved for B12 even though their blood level looks borderline acceptable. The NIH recommends checking methylmalonic acid when serum B12 falls between 150 and 399 picograms per milliliter. Elevated MMA, above roughly 370 nanomoles per liter, is the most sensitive and specific functional marker, with 98% sensitivity for catching true B12 deficiency. Some practitioners now also test holotranscobalamin, which measures only the active, cell-available fraction of B12, providing another layer of diagnostic precision. And here is where the global disagreement matters. Japan and some European countries set their lower limit at 500 to 550 picograms per milliliter based on neurological criteria. The United States sets it at 200 based on blood criteria. A 2025 UCSF study published in the Annals of Neurology tested 231 healthy older adults whose average B12 sat well above the American deficiency cutoff. And even in that group, lower levels of active B12 correlated with slower cognitive processing and greater white matter lesion volume in the brain. The lead researcher, Dr. Ari Green, put it this way, and I am quoting directly, "Revisiting the definition of B12 deficiency to incorporate functional biomarkers could lead to earlier intervention and prevention of cognitive decline." When you speak to your doctor, ask not just for a serum B12 level, but also for methylmalonic acid testing, especially if you take metformin or a proton pump inhibitor. Section 8. The warning signs to watch for. Let me walk you through the symptoms of B12 neuropathy, because catching them early is what separates reversible damage from permanent damage. Paresthesias come first, tingling and pins and needles sensations in the toes and feet. Decreased vibration sense is often the earliest finding a doctor can detect on examination. Numbness, burning, a cold feeling in the feet, and subtle unsteadiness while walking all belong to the early picture. But here is a clinical reality that too many doctors overlook. Neurological symptoms from B12 deficiency can appear without any anemia or macrocytosis at all. A landmark study in the New England Journal of Medicine by Lindenbaum-Helton and colleagues found that 28% of their B12 deficient patients had zero blood abnormalities. Their nerves were deteriorating while their blood work came back clean. A dangerous wrinkle makes this worse. High folic acid intake, including from the mandatory U.S. food fortification program in effect since 1998, can correct the anemia that would otherwise alert your doctor while neurological damage advances silently underneath. Researchers found that cognitive test scores were actually lower and MMA levels higher in people with low B12 combined with elevated folate compared to those with low B12 and normal folate, which means excess folic acid may actively worsen the neurological toll of B12 deficiency. Late symptoms are the ones you never want to reach: spasticity, severe balance problems, difficulty walking, bladder dysfunction, and cognitive impairment that can progress to dementia. One pattern relatively specific to B12 neuropathy combines absent ankle reflexes with hyperactive knee reflexes, reflecting simultaneous peripheral nerve damage and spinal cord involvement. Conclusion: let us bring all of this together. Somewhere between 10 and 40% of adults over 60 are low in B12, depending on how you measure it. Age-related stomach changes drive much of it, and common medications like metformin and proton pump inhibitors accelerate the problem. When deficiency goes undetected, it quietly eats away at the myelin sheath that protects your nerves, and the damage slides from reversible to permanent over the course of months. But when caught early, the evidence tells a different story. B12 supplementation can genuinely reverse neuropathy. Some patients feel improvement within 2 weeks. Most see measurable recovery over 3 to 6 months, and the treatment is safe, widely available, and inexpensive. 3 things to do after watching this. First, if you are over 60 and experiencing any tingling, numbness, or balance problems, ask your doctor for both a serum B12 test and a methylmalonic acid test. Second, if you take metformin or a proton pump inhibitor, get your B12 levels monitored on a regular basis. Third, do not wait. The window for full recovery narrows with every month that passes. A 2025 review from Walilik University examined vitamins for nerve regeneration and concluded that B12 is the only vitamin currently recommended in clinical guidelines for neuropathy management. That is not a wellness trend. That is medical consensus backed by decades of research and 2 Nobel Prizes. If this information helped you, share it with someone you care about. This is the kind of knowledge that can redirect someone's health, but only if it reaches them in time. Thank you for watching.